Rounds for the Department of Medicine, University of Toronto. I'm Arno Kumigai, the Vice Chair of Education. I have the pleasure of introducing these series of conferences. For this one, it's a special citywide medical grand rounds that's hosted by Sinai Health System, and I would like to turn over the proceedings to Dr. Chaim Bell, who's the Physician-in-Chief at Sinai. Please, Chaim, go ahead.
Thank you. And what a nice day outside. And just a reminder to everyone that this year Sinai is we're celebrating our 100th anniversary, 100 years since our founding in October of 1923. And this is an auspicious day with a special speaker that acknowledges what our inaugural Chief of Medicine for when Sinai moved to the University of Toronto, and that's Barney Barris. So a couple of words about Barney Barris. Dr. Barney Barris was born in 1921 in Toronto. He graduated from the University of Toronto, Faculty of Medicine in 1944, and completed his internship soon thereafter. He returned in 1951 after completing his internal medicine residency at the University of Minnesota. He became the Chief of Medicine at Mount Sinai Hospital in 1964, soon after it realized a full university affiliation. He was known around Sinai as the doctor's doctor, and he was renowned for his outstanding clinical acumen and exemplary teaching. He served as the Chief of Medicine until 1977 and continued to practice and teach thereafter. He has been credited with helping establish the academic foundation of our department. The Whiteman Barris Academy at the University of Toronto Medical School is named in his honor. We're going to just shift over to Dr. John Flores to introduce our most honorable speaker. Before that, I think Arno's going to read the land acknowledgement, or is it me? Just want to make sure.
Happy to do it.
Okay, why don't you do that, Arno, and then John will go after.
So as traditional for all of the University of Toronto proceedings, we have a moment of land acknowledgement. We'd like to begin with an acknowledgement of the land on which we work, study, and live. We recognize that many Indigenous nations have longstanding relationships to the land upon which the University of Toronto's Department of Medicine is conducted. We acknowledge our presence in the traditional territory of many Indigenous nations, including the Mississauga of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples. Today, this land is home to many diverse First Nations, Inuit, and Métis peoples, and we are grateful to have the opportunity to live, work, and gather on these territories. It is important to note that land acknowledgements are only a starting point for larger conversations. More concrete acts of restitution and transformation are needed to address underlying inequities and blatant discrimination in the distribution of resources between Canada's First Peoples and settlers. Thank you very much. Turning it back over to Chaim.
Thanks. And just again, I'm going to pass the baton to Dr. John Flores, who is the Deputy Chief of Medicine for Research for our department along at Sinai. Sounds like John is muted, I think, again. Just one second. He got muted. John was having some John?
Can you hear me now?
Yes.
Yes.
Right. Okay. I think I solved the problem, Chaim. When I first met Victor Dzau over 40 years ago, he was an early clinician scientist at Harvard, proud of his Canadian roots and his McGill education, and particularly grateful for his foundational experience there as a summer student, learning within a nurturing basics laboratory environment. One could not be helped but struck by his dynamism, his vision for translational research encompassing genomic, molecular, and vascular biology, and by his team-building capacity. His research laid the foundation for the development and clinical deployment of angiotensin-converting enzyme inhibitors, now used globally to treat hypertension and heart failure, thus epitomizing the concept of bench to bedside to population impact. Victor rose rapidly through the academic ranks, becoming professor and chairman of medicine at Stanford, then Harvard, CEO of the Duke Health System, then chancellor of Duke University. Victor Dzau is now president of the National Academy of Medicine and co-chair of the National Research Council, where he has broadened his interests to encompass major issues confronting society today. At the National Academy of Medicine, he leads a strategy of innovation, action, and equity. Under his tenure, the National Academy of Medicine leads important initiatives, including a global health risk framework, human genome editing, clinician burnout, and climate change in health. Dr. Dzau remains committed to serving Canada, including as a member of the Gairdner Foundation Board, the chair of the Scientific Advisory Board of the Peter Munk Cardiac Centre, and the chair of the Advisory Board of the School of Population and Global Health at McGill University. I was particularly struck by Victor's 2022 lecture in The Lancet. Has traditional medicine had its day? The need to redefine academic medicine, and judge this to be the ideal theme for our 2022 Barris Lecture and our citywide medical grand rounds. Victor, welcome back to Toronto, albeit virtually.
Thank you, John. What a great honor it is for me to give this lecture. And John, your leadership and your friendship with me for, 20 years, 40 years. It's greatly appreciated. And thank you, Chaim and Arno, for hosting this. Mount Sinai Grand Rounds is a citywide Grand Rounds of Toronto. And thank you, Vince Chin, for making it happen. You know, for me, Toronto is a mecca of academic medicine. When you look at all the components that come together, that is making such huge impact. I'm just so honored to be giving this lecture and maybe talking about where we should be going in academic medicine. So that's the topic of my talk today. Can I have the next slide? So I'd like to begin by looking at history of medicine. When we all trace back, at least the Western practice, is Hippocrates, the great philosopher, who actually saw the need for humanity caring for the sick, alleviating pain and suffering. And of course, we all take the Hippocratic Oath, and the newcomers every year take them to look at integrity, humility, honesty, and compassion. That's what our profession is all about. And the traditional history is the art of healing, because we've seen tremendous evolution in the medical practice from home and bedside visits, as depicted on these two paintings in 1891 and 1897 in UK and United States. The doctor who makes home visits, sitting at the bedside. But you know, in the last major advances in the 20th century and 21st century have resulted in the emergence of many specialties. So today we're dealing with general practice, primary care, and many surgical medical specialties. But I think the good news is that we certainly emphasize the importance of patient-centric approach. Next slide. So I think that we should all be very proud of the ethos of medicine that connects healthcare providers everywhere across the globe. Here you can see during COVID-19, the crisis, how we all have stepped up, doctors, nurses, healthcare providers, to look at treating the disease and helping the sick, relieving suffering and saving lives. And so patient care is the absolute first priority for our profession, and I'm very proud of it, and should all of you, health professionals. Next slide. So when we look at the focus of today's medicine as we practice and research, we emphasize individual patient care, diagnosis, treatment, and management. Our research emphasizes on pathophysiology, cellular molecular biology, function, dysfunction, mechanisms of disease. And our clinical emphasis is clearly about the patients, the disease, the managing the quality of life, no less looking at disease deterrence, prevention, and socioeconomic behavioral factors. I'm talking about our practice of medicine today. Next slide. But you know, so much has happened last century, and we should be very proud of this. Major advances in hygiene, nutrition, vaccination, road safety, and research had led to almost doubling of life expectancy in 100 years. And I'm a cardiovascular researcher like John Forrest. I'm very proud of the fact that 50% reduction in cardiovascular mortality in 50 years, really impressive. And when you look at what's going on in biomedical breakthroughs, even with speak, we know that the COVID vaccine and the mRNA platform and so many other things are a result of science and technology, investment, good research, genomics leading to new diagnostic therapeutics, genome editing, gene therapy, potential cures, big data and artificial intelligence, and of course, prevention, and of course, new ways of treating these like immunotherapy. Next slide. So while we're all celebrating, I think the world continues to see major health challenges. And despite these advances, we're not out of the woods. In fact, things may be getting worse. We see infectious disease outbreaks, COVID-19 is an example, non-communicable disease, aging population, climate change, and of course, health inequity, to name a few. These are global challenges of our time. Next slide. So I think the reality where we are today is that we're ever more interconnected and we're ever more related to an environment and our cultures and our communities where we live, work, and we a society at large. So given that, you can know that disease is going to spread more easily, with the interconnectedness, but also the fact that we live in our environment, the social construct is so important about what we do in our health. Next slide. So let me take 1 minute to look at infectious disease outbreak. If you look at the 21st century, starting in 2003, you all recognize, and particularly in Canada, SARS, but all the way recently to COVID-19 and mpox. So it really says our environment is really changing. Global connectivity, deforestation, urbanization, human-animal contact, of course, leading to climate change. Next slide. But I think what's happened is in COVID-19, we learned how unprepared the world is. United States, Canada, and globally. We saw tremendous global inequity. We saw the lack of a strategy coordination, response to outbreak, poorly coordinated ecosystem, certainly at the beginning. The problem of nationalism, where every country needs to take care of citizen, and understandably, and therefore there's no solidarity. Vaccine is a good example of that. The importance of social cohesion and trust. At the end of the day, when we think about our individual patients, it's really about where they live and do they trust us, and is there social good together. The governance and financing of health, and of course, when we look at public health and healthcare delivery, it's really unprepared and poorly integrated. Next slide. So when you look at the fragmentation of the health system, you can see that traditional medicine that we practice in public health are really, in many ways, function in parallel pathways. And we have poor resource sharing together, allocation availability, workforce shortages, both in healthcare providers and public health workers, poor public health infrastructure, and inadequate communication collaboration between healthcare delivery and public health. As DG of WHO says, Tedros says, industrial countries like us, confident in the medicalized nature of a strong health system, or seemingly strong system, lack the human and local touch shown by countries where health workers went door to door, providing essential primary care services, look for warning signs of infection, community level. That's what I want to talk about today. Are we fit for purpose in the long run? Next slide. Well, we see in Canada, next slide, the same health system fragmentation. You have a decentralized public health system with 13 regional systems and many subsystems. And so, the response are really determined at provinces and territories and even cities and lower levels, a lack of coordination at national level. So when it all happened, everybody's scrambling, like United States. By the way, this is reflective totally of the United States. And because data in understanding who's being affected and how are things going and what are the equity issues are not collected in any systematic way. So lack of data integration, lack of coordination, and some areas really don't even have automatic data access and sharing. And data sharing is handled by low-tech methods, just like in our CDC using fax machine, you name it. And of course, you saw vaccine challenges with not having manufacturing capacity, issue with accessibility, hesitancy, community engagement, and of course, delivery issues. Next slide. So I say all that as a signal that we have lots, COVID has uncovered many issues that we're not doing well, despite the great advances in science, despite the great work everybody does in individual patient care. But I want to remind you that actually the disease burden globally is more on NCDs than infectious outbreak, as you can see here. I serve on the board of IHME, and we have enormous amount of data showing about the burden disease in different countries, different counties, different states, different provinces. Next slide. In the United States, of course, we all know the leading disease burden is cardiovascular, cancer, musculoskeletal, and chronic NCDs in particular. Next slide. In Canada, the same. Cancer, cardiovascular disease, musculoskeletal, and of course, the non-communicable diseases along with infectious disease. So we have a long way to go as we look at the disease burden, in addition to the infectious disease outbreak. Next slide. And we have, in fact, many challenges. When we look at how we address these challenges, in US, high cost, access problems. Our system is highly fragmented with no central system. As you know, we don't have universal health coverage. We have somewhat of a challenged public health infrastructure. Our mortality morbidity rate and maternal is highest among OECD nations. We have the issue of deaths of despair, where you have alcoholism, substance use disorder, and many others. We have, like you, mistrust and misinformation, because at the end of the day, we know the social determinants are major issues that underline these challenges. And I wrote in Lancet that really, when you talk about health equity, you can reach it without social equity. Next slide. In Canada, as I look at it, I know that you are, as some people use the word, a health crisis, because you have inequities in socioeconomic, rural, indigenous population. You have a decentralized system where healthcare is provincial and territorial, responsible for financing, regulation, administration. With 100 different authorities, you have gaps in Medicare coverage, primary care challenges, with 22% Canadians don't have a family doctor, primary provider. In Ontario, 2.2 million without physicians, family physicians. And of course, this reflects mainly the vulnerable population. Long wait times, challenge integration of primary care, specialty care, workforce distribution, the burnout issue, and of course, the aging population, lack of long-term care resources. I think we both face, or both countries face lots of challenges. Next slide. And I think to top it off, I think it's reflected while we're celebrating the great successes, we begin to see erosion of our system. I mean, for the first time in the United States, we have seen drops in life expectancy in 2021, 2022, and surely 2023. And this is the sharpest decline in life expectancy. And where we're seeing life expectancy, people like myself and others are enjoying a good life expectancy, in fact, increased life expectancy. What happens is the marginalized population have a drop in life expectancy. So we're seeing a splitting of the curves, two curves, the tale of two cities, so to speak. And those who have less access and less opportunities are living poorer lives. You begin to see that in Canada too. You are in better shape than we are. You have a longer life expectancy, but you are certainly beginning to see disparities. But when I look at the data in metropolitan areas, take Vancouver, I still remember visiting UBC and read a newspaper article to say that between different regions of Vancouver, there could be as much as, actually that time, 15 years life expectancy, driven very much by substance use disorder in others. And I'm sure it's the same in Toronto and elsewhere. And we all know that zip code matter more than genetic code. And so what does that all tell us? Next slide. It tells us that we need to address the fundamental issues of social determinants, and many of which are driven by disparities in health and racial disparities. You know this data in Canada better than I do, that prevalence of diabetes is higher in South Asians, Black adults, Arab and Western Asians than white. But I think overall disease burden are particularly higher in many of the communities of color. And they're likely to less feel that their healthcare is good or excellent by survey. And marginalized groups really feel exposure more to life stress, work stress, and their overall life satisfaction. And I know there's huge inequities to care, less contact with providers, dental, and a regular source of care. Next slide. Now, you don't have as big a problem as we do with regards to the Black population, and Latino, and others. But I think we all know about Indigenous health in Canada. Although a small 5 population, but it says a lot about the issues of inequity, the issues of racism, discrimination, institutional bias, the issue of health disparities, the issues of mental health, and of course, the impact of residential school practices. You know this well, much better than I do. Next slide. So I think one of the issues that we need to now confront as healthcare providers is the issue of social equity, social determinants, racial, ethnic, and other issues. And my good colleague, Mike McGuinness, and this one also from, of course, Professor Mohammed, have written so much about social determinants. In Mike's work, which was written in the late 1990s, he pointed out that healthcare only accounts for 10% of health outcomes. The rest is genetic, behavioral, social, and mental factors. This was very much shown by the great work of Michael Mohammed. We think about, of course, economic stability, neighborhood, physical environment, education, food, jobs, housing, healthcare system. These are all determinants, and more recently, of course, environmental determinants of health, and many others. Next slide. So when we look at this issue, we recognize that to improve the health of our population, and even individually, we need to look at our health practices totally differently or somewhat differently. So I think we as practitioners, I know all of you care about your patients and do ask questions about where do you live? Can I be of any help? How are you doing with food and whole bit? But I think the issue is much more than that. It's not only the individual patients, it's the environment in which they live. So in our National Academy, used to be called the IOM, in 1988, we said the future of public health is moving from not only vaccines and epidemiology, but preventive services, chronic disease prevention, surveillance. And then in 2012, we wrote the future goes further, look at social determinants, equity. And Ken DeSalvo, wrote in this paper in 2016, says public health 3.0 should have equity, determinants, cross-sectoral actions, accountable health communities. Next slide. So what I'm talking about is the fact that public health needs to change, but we as care delivery need to change too, along the same pathway. When we think about how health is delivered, certainly in my country, I think yours is, we operate in separate tracks. We operate in public health tracks that look at assessment, assurance, policy, prevention, health prevention, promotion, care delivery, direct patient care, diagnosis, restoration of care. And then where there's a whole community health initiative or activities where community health workers are given local care in our country driven by actually non-government organizations and doing really important work. I think if you look at what's happening in the developing countries, they become the bedrock of public health and healthcare. being able to go from door to door and really delivering care. It's time that we bring these things together. It's time that we effectively use our care delivery to extend to community health and work along with public health. Next slide. So back in 2012, we actually wrote a report to say primary care and public health should integrate because we should have shared goals of population health, community engagement, aligned leadership, and sustainability. Next slide. And then in following up in 2019, we say it's not only healthcare, it's social care. We need to integrate care delivery with social care and really, in many ways, health with social and other economic important issues. The importance of not having fragmented the whole well-being of individuals and population into integration of social service, delivery of care, effective interpersonal teams, getting data technology, financing models, and incorporating activities. That was 2019, 2012-19. We're still not there yet. But I think the good news is the drumbeat is getting louder and louder, and people begin to understand that at the end of the day, it's all about the individual patients and it's all about the population. And we need not to fragment the things that are important to them, but try to bring them together. Next slide. So this leads me to talk about population health. Of course, you all know it, you practice it, but I would say for academic centers, you have to understand this is convergence, practice, and science. I wrote a paper in Lancet 2018 to say, if you're going to do that, you need to converge not only public health, community health, and healthcare, but you need to bring together social behavioral science, social economic, environmental determinants, public health, law, and many other disciplines to really come together to improve the population health. You can't do this healthcare alone. Next slide. So finally, we all know the importance of health data. And I'm going to talk more about this because the availability of health data will help us to make better decisions, understand much more about the challenges in health of the people we serve. And therefore, we need to bring all this data together with a massive growth in available data. It's time that we actually bring them together. Complexity, diversity, speed in which they collected, allowing us to look at more specific risks and customized engagement, and of course allows us to understand the patient environment and system in which they live. So given the setting, what I'm saying is traditional medicine needs to change. We need to embrace all these issues for us to be able to do our work. In addition to the great work that Mount Sinai does in this hospital with great care and the great specialty care and primary care, we need to really connect with the rest of our community to see how we can improve the care and the data that we can collect. Next slide. So I wrote in the paper Lancet that 21st century health challenge will require today's medicine to revisit its fundamental ethos and to extend its approach with new partnerships and new tools. Next slide. So C.K. Francis, I think, wrote this really important paper about ethos of medicine versus public health. And he said, there's a need to balance today's medicine devotion to well-being patient and primacy of doctor-patient relationship with the need of healthcare of the society altogether. And we can do this. So a challenge facing medical profession like us in new millennium is to establish an equilibrium between responsibility to assure quality healthcare for individual patients while affecting societal changes to achieve health for all. And I think he's so right. Next slide. So my point is to go forward, we need to bring together, not to fully homogenize, but to bring together, work together, medicine, community health, and public health, and to increase communication engagement with the community, to look at the coordination of clinical and community services, align with community health workers, look at community health assessment, and strengthen promotion and protection within community, and bring everybody together to use the data that can help us do geospatial mapping, informed decision, identify high-risk patients. Next slide. Now, why is it relevant to you? Well, you are, in fact, the place where you train, you determine research, you determine practice, and train the future generations. And the academic model of bench to bedside of, our countryman, Sir William Osler, is so important, have allowed us over the years to provide great care, to address complex medical problems, to do great research and training. And as academic health centers, such as you are, we've been doing so much of this, but it couldn't be an ivory tower. This picture is written by actually from a Yale School of Medicine publication that looks at the ivory tower of academic medicine. Next slide. So I wrote over 10 years ago that we need to look at academic centers to transform medicine and added the idea of to population. So bench to bedside to population. And the important issue is that we need to continue doing our great discovery work. We need to translate it. We need to put into population, and that academic centers like you should be the system integrator across all the different fragments of health research and healthcare. Next slide. But 10 years later, given the great changes with COVID-19 and others, it compelled me to write a second paper to say, we need to revisit the model I put forward and revisiting altogether whether we are correct. And I would say, yes, bench to bedside population, no doubt, but let's not forget the society, because that's what we hope to make a difference. That, in fact, is the society we serve. Next slide. So this figure is a Lancet paper, and it's actually about what I do at National Academy of Medicine, what you do. When you think about the 4 segments, we do great research, discovery, translation, genomics, gene therapy, synthetic biology. We must continue to do so and translate them effectively so that we can adopt and implement them in implementation science, health service research, and train the appropriate workforce. We have to now think about the population, not just individual patients, understand social determinants, behavioral science, public health, and of course, the global population as well. But I added society because if you really want to, at the end, achieve all those things, driving from left to right is not enough until we recognize that we can make difference in society. Because the genomics, gene therapy are not going to be useful unless society can afford it, can really make implications. Furthermore, many of these great discoveries have social implications in privacy, accessibility, affordability, ethics. So we don't begin to look at what that means to society, we will not be doing our work. So I've added society, and societal implication of what we do, the ethics, security issue, economic issues, and environment and climate change. And down here are the integrated forces that I would ask all of you to think about. The use of data, the use of bringing different science and practice together, and the importance of equity, diversity, and inclusion. And so the rest of my talk, I'm going to talk about these 4 areas: data science, convergence, equity, and of course, workforce for the future. Next slide. So those are my areas of emphasis. Next slide. So first, convergence. I already talked about what's convergence. Well, at the National Academies and MIT, we've written reports, certainly, about what convergence is. This goes beyond multidisciplinary collaboration. It's actually the integration of these disciplines to unify whole to address an issue, vaccine problems. So it's more than collaboration, it's bringing them under your roof. So that means that you're going to have to develop your expertise, if you will, in more social behavioral sciences. But you can also work with university on their expertise, economic policy, and others to improve outcomes. So the recommendation I say is academic medicine must begin to not only work with the rest of the university in their expertise to bring them in, but develop our internal core capabilities, expertise, in order for us to make a difference in population health and all the health that we do. Next slide. On data science, we know how much data can really inform clinical care, critical policymaking, intervention planning. And of course, we know that analytics can give you evidence generation, hypothesis development, and clinical decision support. And of course, these days, everybody's talking about artificial intelligence, generative AI, machine learning, and what that can do. And I think that will require a whole hours of discussion of the implications of medical education, medical practice. We need to be able to understand these things and not actually being reactive to these. So the how thing is to say that academic health centers like yours have to create data infrastructure, build interoperability, and harmonize point of care data with community and public health. So you can usually utilize to actually generate evidence and make clinical decision support. In so doing, you have to collect socioeconomic data, research data, broad data sets, and share and have information exchange. And importantly, really understand what's the future of AI in what you do. And there's a lot of discussion these days. And of course, we're happy to engage with all of you and us to say, how do we actually code of conduct? How to shape the AI? Because I do believe AI is here to stay. And I think we just need to figure out what's the best way to use it to make sure there's no misuse. It will change enormously the way we practice medicine, maybe freeing more time with our patients. And that's great. And maybe enabling education in a very different way. And of course, our workforce have to be able to understand these issues in order for them to be able to use in the future. Next slide. And I can't emphasize this issue enough. You know, as doctors and health systems, increasingly we're using the word social determinants. Over 10 years ago, when I was using those words, there are fewer people, but I think everybody understands how important it is. But I think we're still using it in terms of the individual patient environment. I want you to think about more than that, because the social environment determines the health of everybody. And therefore, we have to think about social determinants in a broader way of our society. And community organizations, we should work with them to address these social issues in job creation, food, security, education, you name it. And we have to look internally at our own structures. And of course, for us in the United States and for our National Academy, we really have lots of work to do in the diversity, equity, and inclusion issues. But we have to walk the talk. And I think for all of you, the same issues. And of course, finally, recognizing the important relation with health society, you as an anchor institution at St. Michael's, in the environment in which you work and the large number you employ, you can actually influence in your immediate community the work they do, the economics, you name it. We call you the anchor institution. And I think this is a little uncomfortable for many of us, including myself, but we got to be involved with policy issues to promote social equity, cohesion, and trust. And of course, we need to tackle misinformation and gain public trust. Next slide. Finally, I want to talk about workforce of the future, because we now will have to create a new type of clinician researchers that really is more prepared to look at the issues I talked about. It's not to take away from the fundamental great work of discovery science and others, but we do need more clinicians who are more community-oriented, socially connected, and really get skills in communication, know how to talk to the public and patients, because after all, in COVID-19, we didn't do very well. And so we need to partner to think about new curricula and competencies, team science, interprofessional education, which I know you're doing, but really educating people about social inequities and ethics and understanding the use of quantitative sciences. I wrote in Lancet, and I've talked about this, that, you know, if we look at our education curricula, And currently, I think we need to redo this. In the United States, in 4 years, we do 2 years of preclinical. Well, the second half year is doing introduction. The third year is clinical, fourth year is clinical, but people spend a lot of time, believe me, in the United States looking for internship. At Duke, we actually compress the preclinical into 1 year, clinical in year 2. Year 3 is in research and scholarship learning, and many people work in global health. And the fourth is, of course, is what it is. I think with AI and with the idea of different types of learning, we can compress a lot of things into enabling people to be spending more time in community. I also wrote that maybe our trainees, our students, maybe should spend at the first preclinical times in the community working before they even learn how to make diagnosis and use a stethoscope. After all, stethoscope is a tool, but your fundamental values are so important for you to practice medicine. And this should be training ongoing for people already in practice medicine, skills in communication, data already talked about. And so we have to really expand, diversify our workforce, reflect the community and population that we serve, and we have to rebuild the public health workforce. Next slide. Now, Julio Frank and Lincoln Chan and my predecessor, Harvey Feinberg, wrote a paper in Lancet in 2012 called Lancet Commission, which they say the workforce future must reflect, align with healthcare system needs. I added to say, more than ever, we have to take care to be aligned with community and population societal needs. Next slide. So the editor-in-chief, Christine Bigbas Domingo, who was previously at UCSF, and she wrote this in JAMA, that we need a new type of physician, public health practitioners that understand more issues about the issue of public health and give technical assistance to the community partners. So that's certainly one direction that one can think about. Next slide. So this is my second last slide. And it was mentioned by John Flores about the second paper on the World Lancet. Has traditional medicine had its day? And we need to redefine as leaders of academic medicine where it should be. The answer is resoundingly no, because I think the ethos of medicine is so important. We can't walk away from individual patients and the things that trade that we do. But we must extend our focus to more promotion, prevention, aligned with public health, societal needs. My last slide. I know it's a tall order because after all, more and more is put on our plate to say what we need to do. But I think it is a good time for us to say, maybe we need to relook at what to prioritize. I would say to begin with, we need to really retain the important attributes, but we need to evolve. The great challenge of our time is really requires more than the way we've been doing things. They're connected to communities, culture, and society. And to tackle this, we must increase integration with public community health and social issues. So we can redefine our traditional model by going to bench to bedside, to population, to society. And we can do this and continue our great work, but emphasize these 4 areas: convergence, data science, digital technology, community engagement, and equity and educated workforce of the future. So thank you very much for asking me to give this talk, and thank you for providing me with an audience. And I hope that we can have a great discussion after this. Thank you.
Thank you, Victor, for a very provocative, challenging, and inspirational presentation. Jillian, you have the first opportunity to ask questions.
Thank you. That was a wonderful, wonderful presentation. I'm osteoarthritis health services researcher, and much of what you've just said, we have a Vice Chair Quality and Innovation, Kaveh Shojanya, has said to us multiple times, and that is that the big bang at this point in medicine is in the social determinants of health. The problem is our funding. You mentioned the siloing of medicine, but our funding of research is also totally siloed. And I guess the NIH is a bit different than in Canada, but we've got SHRC, CIHR, and NSER. They're like, there's no, so I guess I would like you to think a little bit or talk to us a little bit about how you see the health research funding, or maybe we don't call it health research funding, society research funding, moving forward so that we can actually accomplish what you're talking about.
So Jenny, it's a big issue for all of us, United States and Canada. The good news is our current administration is really big on equity. Now, we recognize these are 4-year terms, and let's hope they continue. So in everything they do, put tremendous emphasis on equity. So we're doing a lot of work with them in looking at all aspects, not just research, but the practice. So let me talk about the practice first. Increasingly, United States, certainly through Medicare, but also in Medicaid, we are dealing with more innovative ways to spend our money, where under the roof of medical insurance and coverage, actually the value-based care allows the companies, insurance companies included, but also lots of Medicaid and CMS to start putting money into social issues that relate to care, such as housing, such as food security. That's a really great trend. So I would imagine that you can think about how you deploy your dollars. First of all, of course, in the province, in the city, and maybe even your own system while you prioritize. I know it's a big order, but it's happening. And I'm very happy that people recognize that by investing upstream is part of health. It's not separate from health. So that's one way to look at it. There may not be a lot of dollars, but it's a good way to start doing this. And maybe talking to your own decision makers, with your system, with your city, with your province, things like that can happen. And they will see, of course, the argument is, you know what, there's going to be better health, less utilization, we save you money, and so be it. It's a testable hypothesis. I think for research, your challenge is clearly true, because first of all, CHR is national, federal, and of course, your healthcare is provincial. I remember I was in the committee that evaluated CHIR performance with Alice O'Hooney and others in this first term, and we said, wait a minute, you talk about health outcomes, but you have no actually connection to the implementation of health. And I think that remains a big problem. But however, I still argue that if you look at some of the research being done on health outcomes, I think that should be part of the conversation as well. I recognize it's a challenge, but I thank you for doing great work. We got to keep pushing for it.
Actually, John, I know your hand's up, but we have a very large donation that was made by Novo Nordisk to focus on Mississauga and prevention of diabetes, which Lorraine Lipscomb is leading. And it's actually putting into practice exactly what you said. It's not easy, but we'll see.
Well, Jillian, if you have great data, you can really, in many ways, therefore, transform the rest of the system, right? And, Ottawa, I'm sure it would be excited to hear about this data as all decision makers, because that's what we want, right? Models in which it works.
We have a question from John Mong and also in the chat. So John, you'll go first.
Thank you. So thank you for what I found to be a very inspiring talk. One thing that I've noticed over the past number of years, COVID certainly has accelerated, is a stark polarization in terms of not only political divides, but socioeconomic divides as well. And I'm wondering if you can comment on your experience in how that's affected this sort of work, and any advice to us physicians, in the States or in Canada, about how to navigate that and how to bridge those divides so that we can make our work more effective.
John, you can say that I live this every day. And in fact, I am today in Aspen meeting with the three secretaries of health, the head of Robert Wood Johnson Foundation. We call the Aspen Health Strategy Group that we come together to talk with this. So I would say the following. We have to focus, understand what we're about. And for me, National Academy, which was chartered by US government as National Academy of Science, the foundational organization, 1863, and we now have spun onto 3 academies. We are independent, but we're there to actually address these issues. So I always remember we have to be politically independent. So what are we about, John? We're about health and well-being of our people. So we have to speak up. We have to get engaged, as I said. And we have to speak up, not in a political sense, but more in the sense of our well-being. So let me take you a live example, 2 live examples. The Dobbs decision in overturning Roe versus Wade, right? What do we do about this? So we have to, my feeling is, we have to step in and address the consequences of Dobbs. We're careful to say we are not pro-choice or pro-life, but we are there for women and women's reproductive health. And consequently, I started a whole series of actions in looking at what's the implication of access, what's the implication on the workforce, when in fact we're getting fragmented workforce, different, imagine, from province to province, state to state, with different laws, criminalization, and all that stuff. We are working hard at this, and but we are state neutral. Same for gun violence. This is what this meeting was about, where I am right now, and we have people from all different sectors, if we will say, of the political environment. But we are talking about how to reduce harm, injury, and safety, not to take away guns, which is a non-starter. But there was a lot of people would agree, yeah, we don't want, this is the number 1 cause of suicide in young people and older people. This is the number 1 cause of homicide in women, domestic violence. We care about this. So I think that's what you need to do. Understand what your fundamental values, mission, and ethos, and go towards that, and don't be shy in tackling them.
Victor, we have a question in the chat which relates to your reorganization of the undergraduate curriculum at Duke. The question really relates to whether perhaps we should be reconsidering the acceptance criteria and recruitment in medicine, and perhaps changing the approach that we take to pre-medical education. Any thoughts on how we might modify the cycle before admission?
First, let me emphasize, I did not redo the curriculum at Duke. It was already there, but it was very effective, and only use it to show that our Duke graduates are not any less clinicians than the ones who take extra 2 years of preclinical. And as you know, we're well known for our research, so than any less in the same field. So we got to think about this, and with AI tools, things may change substantially, right? We all have adopted the master approach to problem-based solving, and therefore the rote learning that I did when I was a medical student may change substantially. But I think the issue here is, relooking our curriculum, given the fact I'm also on the bandwagon of the climate change. You can say, how do I squeeze it in my curriculum? How do all this? I think this is an opportunity that we can look at what can be in the future. Now, with regards to people that we admit, I hesitate to say that we should have a vanilla approach, because after all, there's so many people who've done so many great things. At the end of the day, that is in fact not exactly what we expected, all our healthcare delivers. Let me give a few examples. Many of you know I spent a lot of years in Harvard, and 2 of my faculty members are Jim Kim and Paul Farmer. They were admitted to Harvard Medical School and the Brigham Women's Hospital training program as unusual candidates because they're interested in anthropology. Nobody knows what medical anthropology is about anyway. But look what they've done using their background. And we have many, many people who's done great things, including basic researchers who really took their learning. So I think the fundamental issue, John, I believe, is where their value statement is, where the commitment is. If they are looking to make money, they're looking to go into venture investing and stuff like that, I say, no, that's not the starting point we want. Some of them may end up doing great things. Starting point is we want people to contribute to health and well-being by being committed and have fundamental values. And, we all worry about physicians, scientists. So I want to take away from those who are interested in research. But I think the value statement is the key issue.
Thank you, Victor. And with that parting remark, the hour is nigh. We all have appreciated your lecture. And Chaim Bell, thanks to you for your thoughtful insight in giving the Barney Barris lecture, acknowledging a foundational chief of medicine at Sinai Health. And
well, I want to thank all of you because I know my friends in Toronto and Canada have so many of them. I just feel I'm part of you. So whenever I can, I'll do whatever I can to work with you and hope you do the same with me.
Great. We'll be back. Take care.
Yeah.